Hello, good morning. It is still just morning. My name is Tamsin Ford and I'm a Professor of Child and Adolescent Psychiatry who started at Cambridge University last October. And I'm here to think with you all a little bit about how we can support the mental health of children and young people as schools and universities and further education colleges open up. So, without further ado, I will start by setting the scene a little before we talk about how we support children and young people to cope with the situation that we're in. When we planned this, we thought we'd be coming out of lockdown, but I think that was probably absurdly optimistic, wishful thinking more than anything. So to set the scene, the slide you see in front of you has 3 data points, one in 1999, one in 2004, and then another one in 2017. These are very large national surveys that we should be extremely proud of. They're internationally among the best, if not the best, in the world. The 1999 survey involved 10,500 youngsters aged 5 to 15. We convinced the government to include 16-year-olds to make it more comparable with other studies by 2004. And actually 2017 extended the age range down to the age of 2 and up to the age of 19. But obviously we can only compare where we've got the same data. These surveys involved multiple informant standardized diagnostic mental health assessment. By that, I mean that parents had a face-to-face interview with a lay interviewer who asked a combination of structured questions, but if there was a question they asked, if there was a problem area, they then went on and asked some sort of more open questions to get a bit more detail about the difficulties. Young people, if they were aged 11 or over, also had a similar interview. And if the family agreed, we mailed a shorter questionnaire to teachers, and then a trained group of clinical raters, so child psychiatrists, child psychologists, pediatricians, worked very closely together to put the information from everybody together. And these were government-funded surveys, and the question we were addressing was, if I saw this young person in the clinic, do I think they need an intervention? So we were measuring clinically impairing mental health conditions. And there were a lot of screaming headlines at the time about the crisis in mental health, which we're getting to a certain extent today. And in fact, you'll see there is an increase in the school-age population who are suffering. So we have all young people together in blue, the green is boys and the purple is girls. There was an increase. It is statistically significant. It amounts to quite a few young people across the population of the UK, but it wasn't anything near the kind of epidemic that some people feared we might find. And actually this increase in mental health conditions was almost entirely explained by emotional disorders, so clinically impairing anxiety and depression. And by that I mean symptoms of anxiety and depression at one end of the spectrum are normal reactions to the slings and arrows of everyday life. But if they are persistent, if they are severe, and if they get in the way of being able to function, to do the activities that you need to do to get by, that's the point at which they tip into a clinical disorder. This change was seen in girls as well as boys. And as I said, this 2017 data went down to the age of 2 and up to the age of 19. And what you can see here is there's a steady increase in the number of youngsters who meet diagnostic criteria across the age span as you get older. There are interesting differences between boys and girls. So boys are in green and girls are in purple. And amongst the younger children, it's the boys that predominate. And then by the time you get to the older teens, girls rapidly overshoot. And this is what we see into adult life, with much more common anxiety and depression in particular amongst women than men. So reasons for that switch are interesting. It's partly to do with the types of disorders. So boys are much more likely to have neurodevelopmental conditions than girls. An interesting aside, if you do these population-based surveys where a sample is taken from the population, the first two surveys used Child Benefit Register, which we couldn't use in 2017 because it was no longer universal, so we used GP records, but it's a population-based sample. The ratio of girls to boys with ADHD, for example, is about 3 to 1. But if you look in clinical samples, the ratio is about 9 to 1. So girls are less likely to have these difficulties, but if they do, they are less likely to be recognised and picked up, which is interesting. And then, as I said, by the time you get to the late teenage years, the girls with emotional disorders are far commoner, far more likely to be struggling than the boys. And if I go back one, if you see here, there's nearly a quarter of our young women were meeting mental health criteria. That's seriously alarming. So that was the finding in 2017 that made us all sort of think, wow, that's worrying. And of those with the disorder, half of them were self-harming and about the same number had more than one disorder. There have been a parallel, in fact, more frequently repeated surveys in the adult population. And these started at the age of 16 up and now go into the 80s. The first one was working age adults, so it went up to 65. And we see the same pattern there. So there were surveys in 2000, 2007 and 2014. And in 2014, there was a sudden leap amongst young women in particular, but youngsters between the age of 16 and 24. Again, anxiety, depression, and self-harm. So I am now convinced that in our own country, we have something serious which is going on with that age group. And this feeds into those of us who work in the university sector know that there have been an increase in mental health problems amongst our students, and also sadly some suicides, which is exercising a lot of people's minds. Now, there have not been extensive analyses yet of the 2017 data, but an analysis carried out by ONS showed the following factors. This table in front of you is primary school children, which when you adjust for all the background characters, interestingly, it's white working class kids who seem to be struggling the most. The colour code is where it's green, which is for gender. That is because it changes. So for behaviour disorder in primary school children, and for any disorder in primary school children, probably because behaviour disorders are the most common, boys are more common, and you'll see in the next table, girls are more common. Where it is purple, it is because it's a fairly ubiquitous finding, and I think it makes us, you know, some of these are tractable. So family functioning and poor parental mental health, for example, and low income or being on disability benefits, which given the coming recession, we need to be thinking about. And in black, these are factors that were important only for one age group or one disorder. And again, this is for the secondary school age, and you see that emotional disorder being female is much more likely, whereas behaviour disorder, again in the teenagers, much more common in boys. Unhealthy family functioning, poor mental health in the parents, and socioeconomic deprivation. However, those who have a mental health condition are not a separate group. So that means for the 1 in 8 that meet of school-age youngsters that meet diagnostic criteria, there are probably 3 or 4 others that are also struggling, in that they're scoring well above average, well above the mean, but they're not quite meeting diagnostic criteria. Now, Jeffrey Rose, a very famous epidemiologist, would argue that pretty much every health condition is a normal distribution like this, the old bell curve. Those blue arrows on these graphs are the clinical cut points on a very commonly used scale called the Strengths and Difficulties Questionnaire, which is a general mental health screener for children and young people. And what's fascinating is it asks the same set of 25 questions to young people on the far left of your screen, to parents, and to teachers. And as an epidemiologist, I am fascinated by how different the curves are. We're cutting off, even in the young people, but particularly in the teachers, the children who are doing better, who are thriving. And then what that says to me is that if teachers complain, we need to listen, because actually they're less likely to do so given these questions. But the point I'm getting across is that we don't only need to worry about those who meet diagnostic criteria, which are, you know, a little bit arbitrary and very much related to the community, school and family resources. So one child with the same difficulties might really thrive in one situation, but might really struggle in another. That's good, because it's one of the things that we can use to help. One other thing to set the scene I want to say is that sadly and worryingly, not only do we have deteriorating mental health, but we have evidence that for children born in the current century, their outcomes in terms of health, education and social difficulties are worse than cohorts that were studied in the previous century, which is bad news. So we have deteriorating mental health, and it's having a bigger detrimental impact. Some of the impacts are quite severe. So for example, this graph presents data from a PhD student of mine, Claire Parker, photographed on your slide, who used the 2004 National Survey and a 3-year follow-up to examine psychiatric disorder, but also mental health. But the slide shows you disorder in terms of being excluded from school. And by that, I mean being suspended or expelled. And even adjusting for this big list of other explanatory variables, youngsters were between 2 and 4 times more likely to have been excluded 3 years later if they had poor mental health. The impact on your ability to function if you have a significant mental health condition, particularly in childhood and adolescence, is heavy, because everybody else is developing away from you whilst you're not able to function, and it's hard to catch up. I should say there are also associations between mental health, particularly anxiety and depression, and attendance at school. And that is a way that schools could be monitoring if there's a sudden change in attendance, or indeed function in terms of academic work or behaviour in school, what's going on. And I'm going to pick that up again later. So then COVID's happened, and all of us have had to make massive adjustments in terms of everyday life. And we have a real data gap. Our national surveys are mostly adults because it's easier, there are no issues with consent. There is a real lack of high quality data out there on which modelling can be done in the same way as it's being done with adults for children. Russell Viner, who is a professor of paediatric epidemiology at UCL and also the president of the Royal College of Paediatricians, he and his team have done a systematic, rapid review of the evidence around the impact of school closures. And what is clear is the impact of school closures on children's health and well-being and academic attainment and social functioning in the medium to long term are much higher than any of the emerging risks. So we have a situation in which children are less affected, less susceptible, and less likely to transmit COVID, but actually they are going to bear the brunt of much of the impact of lockdown. I think one thing we have seen is a plethora of convenience samples, lots of questionnaires. My teenage daughters have been absolutely scathing about some of the ones that have been pushed at them through social media in terms of the questions asked. And although there is a tension in terms of we need data, we also need good quality data. And whilst it is very quick to get something on Qualtrics or SurveyMonkey up, and you don't need ethics necessarily if you're, consenting online, those convenience samples tend to fail to reach the most vulnerable. Even the more systematic probability samples that are carefully constructed and weighted fail to reach them, but the biases are bigger in these, quick and dirty surveys. On the other hand, having some quick and dirty data when you have nothing may well be better than nothing in the short term, but in the longer term, we do need to pay attention to the quality of the data, because like most things, if you get rubbish in, you're going to make poor decisions. Just to dispel some myths about this, larger samples do not adjust for bias. So there is a study that came out of China on mental health, which had 52,000 people, but over 65% of them were women in a country that has well under 50% of the population are female. So it might tell you something about women, but it's going to be vastly inaccurate about men. Waiting for non-response when it's as extreme as it's likely to be in a convenience sample only partially addresses bias. You can't be sure that you've got it out, particularly when you don't know the sample frame. So if you start with a carefully constructed sample frame like the Child Benefit Register or GP records, you know who you haven't got, and you have some, you don't know the individual details, but you have an idea of which groups of society you haven't reached. The other really important point is that non-probability samples lack a theoretical basis for the uses of statistics, which are all theoretically based with a number of really important assumptions on a random sample or a probability sample. For those of you who are interested in research and to give a sense of the size of the problem, I'll point you at this living systematic review by some heroic colleagues in Canada in McGill University. So they realized very quickly that we have this huge signal to noise problem. They are doing 3 systematic reviews, one that's looking in changes in mental health with pre-COVID data on the same people linked to post-COVID. And then they are doing surveys that do link individuals during COVID, because they can tell us about how things have changed. And then they're doing randomized controlled trials about ways to intervene. When I last checked earlier this week for another talk, they had screened over 21,500 abstracts, from which they had found 300 trials were registered, of which 53 were of suitable rigor to be included. And the studies, the more observational studies about mental health, slightly over 50. So the signal to noise ratio is extreme. Well, what about those studies? Not one of them on the database, the last time I checked, related to children. So this is what I mean about the data gap. Some of them go down to the mid-teens, 16 plus, but we have nothing on younger children. There are 2 that I'll talk about that are available but haven't filtered through to the database yet. There are some interesting studies on university students, but they tend to be quite small. They suggest the depression symptoms are increasing in more than anxiety in this group, but both were increased in 4 out of 5 studies. There have now been 7 population-based studies of adults, including one in the UK, which suggests small or negligible increases in anxiety or depression. Although one of the UK studies, the Alspach mothers, now Alspach was a cohort of youngsters born in the early 1990s. They're sometimes referred to as the children of the 90s. So of course they're in their 30s now. This study also used a cohort from Scotland who are in their 50s, which is interesting. If you think about the signal pre-COVID was that mental health was deteriorating amongst young people and women in particular. But the Alspach mums show a large decrease in well-being and an increase in psychological distress rather than clinical levels of disorder. There is an interesting international cohort who had a rare medical condition who were more anxious. Now that makes sense to me. If you have a condition that makes you more vulnerable to get seriously ill, it would make sense that you're anxious. And likewise in a lesbian and bisexual, gay and transgender sample in the States. Probably the most rigorous study in the UK that's published is this UK longitudinal survey. They have up to 8 waves on many people. And what they showed is over the last decade, there has been a deterioration in anxiety and depression symptoms as reported on something called the General Health Questionnaire. So it reports both at the same time. But between the last measure and data taken in May this year, there has been an acceleration in that deterioration across the board, which is worse amongst those who were young, so particularly 16 to 24, but also now 25 to 30, particularly women and younger women, obviously it's a double whammy, and those living in socioeconomic deprivation. I don't think it will surprise any of you who are parents of school-age children that the parent, somebody who was reporting who was a parent of a child under the age of 5, that seems to be a newly emerging vulnerable group. And of course, there's a whole literature about the impact of parental mental health on children's development and the child's mental health. I think it's worth mentioning some of these convenience samples because of the hints that they show. And of course, these were the first data that were available until very recently. So Young Minds sampled their panels of people. So these are people with lived experience of mental health problems. And there was a big signal that people were struggling with their mental health, and some of them were also struggling to access support that they needed, which might be explanatory. There is a sample run from Imperial, or a series of surveys collected via the internet of those aged 16 to 24, showing massive difficulties. A third had lost income, nearly 80% had experienced education or employment changes, a quarter had had to change their living situation, and many reported disruptions to healthcare, which importantly was more likely if they were trying to get help for mental health problems. There is a small study from colleagues in Cambridge from the CBU. It's available in preprint and the reference is below. Now these were young children, primary school age children who had been assessed for a different reason, who there was data on, they were recruited from schools in and around Cambridge. You can see compared to the national population that they're quite, they're relatively affluent, and you know, the team are congratulated for getting back to a sizable chunk of them, but it wasn't the whole sample. Interestingly, in this very young group, there was no difference in anxiety or emotional symptoms But there was a statistically significant in depression symptoms, and I find that worrying because depression in such young children is actually very rare. Young children of that age are much more likely to present with anxiety. Again, if you're interested in children and young people, you might have seen this excellent study, which has pre and post data. It's the first to report in this country. 1,000 young people from 17 schools in the west of England. They were in year 9, which makes them between age 13 and 14. And although there is some sort of cross-sectional data, because they got more at the second time point, which is interesting, people sitting around and bored, I suspect, there is linked data between October and April and May this year. I think touchingly, young people were worried about their friends and family, either that they would get sick with the virus or about the impact. Over a third were worried about schools, and a similar proportion worried about the impact of their friends. Overall, at population level, there wasn't a huge impact detectable on mental health. But actually, amongst those who were struggling, there were hints that these young people's mental health had improved. So what you're looking at now is pre-pandemic in blue and post-pandemic in red, split by in the risk range for depression before the pandemic or not. And what you can see is there's a drop in depressive symptoms. We see the same thing on anxiety scores amongst those who are at risk, with almost no difference amongst those who aren't, and an increase in well-being. Now, what that suggests to me is that lockdown either relieved school-related, most likely school-related problems, either special educational needs that weren't being supported, or bullying, or exam pressures, which come out in surveys of children as their number one concerns. But it says some worrying things about how our system, when it's working, impacts those with poor mental health. Another study you might be aware of is called Cospace. It's run out of Oxford. It's a kind of rolling recruitment via social media. So it's a predominantly white, predominantly affluent sample, but it's giving us some useful signals. So it won't surprise anyone who's tried to do this that 3/4 of the parents reported huge difficulty trying to balance work and child's well-being. They were really worried about work-life balance, keeping their job going, keeping their children's education going, and also screen time. I won't go into detail about the pandemic-related anxiety, but the results about the first month of lockdown are really interesting. So parents reported on children, so that's 11 or younger, and we don't have self-report at that age because it's, in research terms, it's not terribly reliable, but worse mental health across the board. So behaviour, emotional symptoms, restlessness was also reported across the age range. So parents reported more restlessness amongst their teenagers as well. Young people reported fewer emotional difficulties, and this was echoed across the age range if a child had known special educational needs or disability or a mental health condition. And young people didn't report any change. So what on earth do we do about all this? Well, I think having stopped and looked at the evidence, we should be trying to keep schools open. They did stay open for the children of key workers and those that schools thought were vulnerable, but to a variable extent, and the take-up was often low. That meant quite a lot of children who were known to be living in vulnerable situations or to have additional difficulties disappeared off the radar of people who try to support them. So we also need some regional and local multi-agency plans about how to deal with these children and to check that they're safe and to support families. Mental health service demand plummeted partly I think because people were reluctant to seek help, and partly because the mechanisms for referral via schools, via primary care were harder to access. However, clinical activity remained at the same level because people were working harder to stay in contact and support the young people that they work with, although that doesn't quite gel with the report from Young Minds of people feeling that they had less support. This may be because there was a switch from primarily working face-to-face, although there has been evidence for the utility of remote working either by phone or by video conference for years. It's just not really been adopted. And it's very clear from data coming back that actually for some families, it's, reduces disruption to family life, it increases attendance and they really value it. But for some youngsters and for some clinical activities, it really doesn't work. And I think as things open back up, we need to work with practitioners and with families and young people to co-produce some guidelines about for whom remote working is a really good option. And there are huge issues about confidentiality and safeguarding when the clinician can just see a little box as you're looking at me in a little box. You have no idea what's going on behind the scenes. And obviously, if you're thinking about child protection or abusive relationships, it's not the same as having the whole family in the room. We also need to do something about the data gap. We still have a massive data gap in relation to children and young people because of appropriate information governance around consent. But children are our future. We need to have good quality data so that we can have good quality decisions made that are evidence-based, and to work through how these are playing out. We need longitudinal data. As the schools are reopening and hopefully staying open, we need to be aware who's likely to be vulnerable. So, I don't want to paint a picture that our children aren't tough. Actually, human beings are hugely resilient. But the groups that we need to keep an eye on are those with pre-existing mental health conditions who may well have felt better during lockdown, but if school is a difficult place to be and they've had 6 months away from it, it's going to be a real struggle for some of them to get back in. And we need to have ways to support them. A punitive approach is just going to undermine the relationship of the child with their family, of both the child and the family with the school. It's really not helpful. We need ways to support children to overcome these difficulties and get back into school, or blended approaches to learning. Some children will have had a very adverse experience during lockdown, and I'm going to talk a bit about that later. A very few will have had the infection. Some may be left with long COVID or neuropsychiatric effects of brain infections. Some may have been traumatized by the experience of family and friends, or even bereaved. And financial strain, as I've hinted, is strongly associated with both the mental health of parents and the mental health of children. And we're going to have more families that are struggling with debt and unemployment. And then let's not forget those with neurodevelopmental disorders for whom school is a bit of a struggle. And they will struggle with the change, particularly those with autism spectrum condition who have a real need for sameness, and they're going back into a situation that's really not the same as they left. I'd like to flag up some really interesting ways of dealing with this should we need to shut schools again. So if the transmission in the local community is not terribly high, the evidence is that transmission around schools is more likely adult to adult contact than child to adult contact. However, if there is a high level of COVID in the community, we might well have to shut down schools again. Obviously, this needs to be as brief as possible. So the ideal situation is at the bottom of this diagram, with a full-time return to school and social interaction after school because social interaction and play is hugely important for the development of young people right the way through from toddlerhood, excuse me, to adolescence. So this work came out of Glasgow, and actually you can see it beginning to work through in the policy from Scotland. The research group interviewed and surveyed a larger group. So they did interviews with 43 parents and professionals working with children across police, the school sector, social care and health. At 2 time points, first at the beginning of lockdown and then in the middle of the summer. And they surveyed a wider group. When they first spoke to parents and professionals, people talked about the loss of support, the struggle of teaching and trying to work, and worries about finance and housing. By June, families had sunk either into a virtuous cycle, so where jobs were relatively secure and people could work from home and they had kit and they had space and the children were old enough and had space and kit to access learning, things were going pretty well. So they were in a virtuous circle, whereas you can imagine the other end of the spectrum is where there's, families are making choices about who looks after their child. They may have to break lockdown regulation in order to be able to work. And if they don't work, they may not get any funding. They may be at threat of eviction if they can't pay their rent. They may not have more than, one device, one computer for a family of 3 or 4 children. So who gets to do their lessons? They might not have individual bedrooms or good enough Wi-Fi, even if they do have the kit. And you can imagine that those pressures stack up on families. And, the police reported the spike in domestic violence that they'd expected to see, although that's somehow mitigated by less drinking and, no football matches and the other things that spark domestic violence. So this team worked with these results with infectious disease modelers and parents and professionals to co-produce a plan for closed childcare clusters to try and take the pressures off families, so that if infection rates go out, you can first of all start by having smaller groups in school part-time to try and keep the schools open. Then you can either use a trusted adult or a grandparent in a cluster or a closed childcare cluster with social contact only with that. And then there will be some, because they're shielding, who will have to be isolated at home, but that should be the minority. And I think that's really interesting, worth exploring more to try and take the pressure of the most vulnerable families. In terms of schools, I was part of a group that did this systematic review for improving behaviour in schools, which came up with 6 recommendations. So there's a short practitioner report, and then there is a in-depth systematic, 3 systematic reviews actually that sit behind it. And one of the key things is teachers and school staff are well placed to know and understand their pupils and can put that knowledge into practice. That we shouldn't focus on just, discipline and managing misbehaviour, but actually children learn by, we all get things might be done differently. There are some evidence-based classroom management strategies that I'm going to talk about, and there are simple approaches to build positive relationships, which are hugely important. I have research from the national survey showing that a parental report of a poor teacher-pupil relationship predicted the new onset of severe behaviour problems, exclusion from school, poorer family function, and other psychiatric disorders 3 years down the line. And just simple things like being at the door of the classroom to say good morning, you need to invest some positive if you're wanting a child or a young person to pay attention to you when you need to correct them about something. And then targeted approaches around the individuals who struggle and are trickier, and consistency across the school within the management of an individual is absolutely key. So we can think about our behaviour and influences for everyone, but this is, you know, aimed at children because it's part of our systematic review, and we all hope we're here with positive behaviour and positive influences around us. However, we all know that if, you know, life is going badly and we're stressed, so we have some negative influences that actually we might start being irritable and reactive and grumpy with people, and we're kind of moving around here. So what we want is the influences at school to be pushing people back towards the positive behaviour and positive influences, with the recognition of understanding that actually we move around a bit. Now, schools can't be expected to influence everything. They can't influence home life. They can be aware of it and how it might be impacting, and we need to respect differences in culture, but that may need understanding and tolerance from school. There are some other things that we can identify via school and perhaps influence other aspects of home life, like, you know, talking to parents about how to support their child with reading or homework, advice for parents about screen time, you know, that there's things that we can do. And then there are things that we can manage in school. So relationships are key, both teacher pupil and you know, stopping bullying and promoting positive ways of resolving conflict and disagreement. The teaching and the learning environment, the school organisation, and building positive attitudes and self-concept. So a few years ago, I completed a trial on something called the Incredible Years Teacher Classroom Management course. It's part of a three-pronged programme that was developed initially to support children with conduct disorder. So that's the high end of behaviour problems. And it has a parenting course that's gone everywhere. It's gone all around the world. And actually, one of the strongest influences on children's behaviour is parenting. And you get no control over who comes to live with you. Some of us score an angel, but most of us don't. And, you know, the way I talk to families who are struggling is, you know, for some children, you need the PhD in parenting. And you know, we're not taught how to do this. But at the time I did the trial, there hadn't been any evaluations of the teacher classroom management on its own. In fact, there have been several now, and this is the programme with the most evidence behind it in terms of improving children's mental health and behaviour. So it's based on very well tied and tested psychological theories, and I've put them up on the slide if you want to go and investigate them a bit more. Basically, I'm going to unpick this complicated slide for you. The intervention is manualized curriculum. It's 6 days, separated a month apart, where you focus with the teachers on building positive relationships, how reinforcing adult attention is for children, how you can coach and encourage the behavior that you want, and to be proactive really rather than reactive, motivation through incentives and rewarding what you want, and using low level sort of ignoring and redirecting for as much of the minor misbehavior or undesirable behavior as possible, but where, you know, there are obviously things that you have to react to, and I'm not for a minute suggesting this is just, you know, you can't tell children off. Children need to learn, and they only learn if you tell them, but you follow through the, if you do this, this happens, and then you're consistent with it. And then there are other things about emotional regulation, social skills, and problem solving. How do we think it works? Well, it improves the focus of the teacher on the child's perspective and their individual needs. It hopefully makes them reflective rather than reactive. The teacher is more aware of their own triggers and therefore calmer, and gets into a positive rather than a vicious sort of whack-a-mole way of managing the classroom. So you have a teacher who's calmer and more in control, paying much more attention to the things they do want. For individual children, they are calmer, happier, clearer about what they're supposed to do, being praised and encouraged for doing it. And at a class level, that leads to more pro-social behaviour. So you hope that there are shared outcomes in terms of relationships and well-being all round. And in the longer term, you hope that more settled children can learn better. And in fact, that's what our trial showed. 6 days training for teachers. Obviously, you couldn't bring it in everywhere, but there have now been 3 trials. There's another big one in process, not too badly disrupted by COVID in terms of lucky timing. And we hope that we can bring this in as part of teacher training and continuing professional development. The data I've flashed up now is from Place to Be, who is a charity who offer a whole school approach to mental health in schools. But one of the things they offer is face-to-face counselling. And this is their outcome data, our teacher report on the strengths and difficulties questionnaire I talked about earlier, and also parent report. And you'll see at the time these children were referred for counselling, this is only primary school children because Place to Be works more in that area, and we didn't have sufficient data for secondary school children then, but we'll go back and do it. You'll see these are just hovering round about the level for clinical difficulties. And then after the intervention, they've dropped down. The population average is about 8 or 9. So not quite to the normal range, but certainly significantly lower. And follow up over a year later, it was lower on both parent and child account. Now, obviously there's no control group. So we used the national survey to carefully match at baseline, and we more or less did it, you'll see here. So the red is Place to Be over time, up to 2 years. And the blue is the controls selected to be as similar to them as possible from the national survey data. And I think that's fairly convincing evidence that this low-level individual counselling in schools had a maintained effect on children's well-being. Coming back to what I said earlier, the vast majority of children are going to cope. They're going to be fine. They've adjusted already and they will adjust to being back at school. And then there'll be some at the severer end who will be vulnerable regardless of anything. Those who already have mental health problems, those who need to go to special schools or alternative provision or have quite severe special educational needs. And in between there is this vulnerable group. And I think if we intervene via schools and supporting families, we have a chance to reduce the impact on them. I have provided some resources with the slides and some references, and I'll stop and take questions at this point. So if I go to the Q&A, one of the first questions is, have there been changes to the diagnostic criteria over time? And if so, is there any change that this has impacted on the numbers? That is an absolutely excellent question. So some of you who will be aware of the diagnostic classifications we have. There are 2, one called the International Classification of Disease that comes out of the World Health Organization, which covers all health conditions, but there is a chapter on mental health. And then the Diagnostic and Statistical Manual from the American Psychiatric Association, which is mental health. And some of you will have been aware of the stink about DSM-5's changes of diagnostic criteria for this, that, and the other when it came out a few years ago. Now, the detailed assessment that we did asked questions that were related to both DSM and ICD questions. And the interview was updated to fit DSM-5 when it came out. So DSM-5 came out between the 2004 and 2017 surveys. But because we were commissioned by the Department of Health, and because it was the same at all 3 time points, the diagnoses made in these surveys were, so the data I've shown you were based on ICD-10. So we had the same measure, the same diagnostic criteria, and as similar a process as we can possibly do, using some of the same people. So I was a clinical rater at the beginning of my career in 1995, and beginning of my research career anyway, and led the clinical rating, the training, and one group of clinical raters in the previous, the 2017 survey. So for the data I've shown you, I don't think changes in diagnosis explain it. However, when you talk about changes in clinical diagnoses, I think changes in recognition and changes in people's willingness to come forward and changes in diagnostic criteria all play into that. So for example, when I was a junior psychiatrist, you know, doing my postgraduate training, autism was seen as a very rare condition, probably affecting about 1 in 10,000. But this is about the time when the evidence started coming in that actually it's a spectrum. And because many people with autism spectrum conditions are high functioning individuals, they can get round and mask their difficulties. And so the conception of autism as a rare condition has changed, and so have the diagnostic criteria. And the prevalence is now thought to be in childhood somewhere between, you know, around about 1–2%. But I don't think that explains what we're seeing in anxiety and depression. One other thing I could have mentioned and I didn't was a very interesting study that was led by colleagues from UCL, which involved looking at these cross-sectional panel surveys in national data for England and separately for Wales and Scotland over a 20-year period. And interestingly, that did not consistently show a change in the brief questionnaires reported by parents or by young people. But what they did show, a very neat and strong trend, was more people being willing to say, yeah, I think my child or I think I have a mental health condition, which suggests that there's a parallel process in that more people are willing to come forward. And that's not necessarily a bad thing if we can only get them on into care. We have effective treatments and they do make a difference for people. And as I hope I've convinced you, the impact of struggling with an untreated mental health condition is really quite severe, particularly for children and young people, because they fall behind and then it's more of a struggle to catch up. So the next question is access to health services or mental health treatment. And again, is a very good question and something very close to my heart. So my PhD was studying access to specialist services, so mental health services, special educational needs, social services and pediatrics in relation to mental health amongst the 99 survey going forward to the follow-up in 2002. So there was a questionnaire follow-up where we asked more questions about survey at about 18 months, more questions about services. And then those who said they'd access services, I actually telephoned and had an interview with them over the phone about what they had accessed and how they'd found it and any problems they had accessing it. And then repeated the same process in 2002. And then we took the service relevance screen negative. So these were parents who had said they were worried about their child's mental health at both time points, but reported no help, because that's really interesting. And what that shows, and a colleague of mine studied service access in between 2007 and 2004 and 2007, and we're about to do it again for this most recent sample. But it's somewhere between a quarter and a third of those with an impairing mental health condition reach services over that 3-year period, despite increased investment in CAM. So we are not doing well. I think, to be fair, there is a similar sort of treatment iceberg in most conditions. So the only other one I could find data for was asthma and kind of wheezing and shortness of breath. And it was very similar. It was about a quarter of the children actually made it through to services. We should be proud that those with the most difficulty are the ones that get help. But I think my colleagues in CAMS will tell you they're very under pressure. The waiting lists are very long. And if you are waiting a year to get active treatment and you're 12 years old, that's quite a chunk of your lifetime and quite a chunk of time for families to cope with an impairing condition. And I think if we were talking about cancer in childhood or epilepsy in childhood or diabetes, it just wouldn't be allowed, you know. And this is at a time when we're going to have less funding and more children needing more help. I'll answer one more question because we're coming up to, well, I might do two questions. We're coming up to the end. If you do have to go off, thank you for your attention, and I hope you've enjoyed the talk. There are two questions that I think are really important. One is quick. Is there information about the samples, such as the percentage of Black and minority ethnic children? There is very detailed data, but it's a population-based sample. So therefore, it represents the population levels of Black and Asian minority children. And there are interesting nuances that we can't really analyse in any detail because we don't have sufficient numbers of them. But there are areas, like there was a cohort that was followed in the East End of London with their huge diverse population, huge number of young people from families who originated in the South Asian countries, and also born in Bradford more recently. Again, another hugely ethnic diverse area. And I think we are pushing for the next survey to oversample children from this group, so we have sufficient what's called statistical power to be able to do a sensible analysis. And the final question is, ignoring the impact of COVID, the deteriorations, can this be attributed to more people being aware of their mental health? Well, I think it's really hard to say, and I would direct you towards Stefan Kolishaw's wonderful work in this area, because he's thought very hard about it. And I think partly, yes, you know, these, I've talked about the study from UCL, which showed that parents and young people were more likely to say, I'm concerned about my mental health, whether that's recognition or willingness to admit to a stranger. So is it increased self-awareness and or is it increased stigma? I don't think we know, but I don't think it fully accounts for the difficulties. And I think I should stop there. I'm sorry if I didn't get to answer your questions. And I thank you very much for all of you who've bothered to submit them. Thank you.